Hello, everybody. So as I mentioned, we still had to finish up the remaining slides. There's not too many from the previous lecture looking at congenital abnormalities and screening for athletics. So that's really what we're going to do here. It should only take a few minutes, but I want to make sure that we're all caught up to speed and that we're ready to move on from here. So if you remember, we ended on talking about Marfan syndrome, which is a genetically inheritable condition. There are a slew of different things that really can be identified in people with Marfan syndrome. So here's some of them, and we had some pictures that you can see in the link down at the bottom there if you wanted to take a look at some noticeable features in real people with Marfan syndrome. So remember, one of the big issues here is actually the heart condition. So, aside from appearances, that's not really a big deal, but they do run the risk for aortic aneurysm in a variety of different locations. And there are some other heart conditions that have been implicated with people with Marfan syndrome. So that's why it's particularly concerning, because it can lead to sudden cardiac death. And we also talked about heart murmurs. So a lot of people actually have heart murmurs, and most of them are benign, meaning that they're not pathological. There's no real reason for concern. And this is especially true in young people. There's a lot of young people that have benign heart murmurs. So you can see here that there are flow murmurs that are heard in about 40 to 50% of young athletes. So this kind of gives you a representation of how many people do seem to have murmurs. A lot of times with some tools and physical examination, physicians are able to distinguish a flow murmur from a pathological murmur. So this next slide is really going to show you, like, sort of compare and contrast how a physician would be able to identify something that's benign and really not of concern versus a murmur that's potentially pathologic that would lead them to then order more tests and try to get to the root of the problem. So if it's benign, it's mid-systolic. So the murmur can be heard right in the middle of the systolic phase, whereas if it's potentially pathologic, the murmur tends to occur during the diastolic phase. The sound will vary slightly. So in benign, it'll be sort of soft and blowing sound, whereas potentially pathologic will be represented through a harsh sounding or loud murmur. Now, if you remember a while back when we talked about blood pressure, there are different phases that can be measured. So S1 and S2 are the systolic first and second phases. So I'm not going to get into the details there, but they can actually break down changes in murmurs by looking at individual timing of the systolic and diastolic phases. Now you can see radiation versus no radiation of the murmur. So you can actually detect the murmur if you put the stethoscope somewhere else in the body. Would really be referring to radiation. So you can see that if you can hear that murmur in the carotids or the axillary vasculature, so more towards like the armpit area, that could be potentially pathologic. But if it's benign, that sound goes away as soon as you move the stethoscope away from the heart. Now with benign, it tends to be louder supine than standing, so laying down versus standing. However, if it's potentially pathological, it might be louder in the standing position. Now, we talked a little bit about the Valsalva maneuver, so it's really common during weightlifting. So if you sort of apply a lot of pressure, like you almost contract your abdominal muscles, I'll try to look something up that better explains how to do this, but if you like push out against some pressure in your throat, so if you can kind of like close your throat but still push air out, you can't hear the murmur when you do that procedure. But if you do that, the Valsalva maneuver, and you can still hear the murmur, it might be potentially pathologic. So these are some of the ways that physicians can try to differentiate these two conditions. So of course, if somebody has a potentially pathologic murmur, or for other reasons, screening tests are really helpful. So we mentioned before, echocardiogram is normally the go-to. We'll continue to talk about that. But of course, EKG or ECG, same thing, echocardiogram, has a lot of useful aspects of it as well. So there are lots of controversies with using EKG, at least in terms of screening for athletics and screening for sudden cardiac death. Of course, the idea here is that it can potentially catch more pathology and possibly save more lives. And so that's why many people would argue for using more EKG tests. However, there are some concerns with false positives and ultimate cost to society. So false positives meaning the EKG comes back and it looks like there's something pathological, but it actually is just a malfunction of that test. So then where do you go from there? One of the biggest concerns with cardiac screening for this population would be if you tell the person, oh, we have reason to believe, let's say based on this EKG reading, that you have a pathological heart condition. Therefore, we recommend that you don't play anymore. So preventing someone from playing the sport that they love has a lot of ramifications. Of course, quality of life and their happiness, or what if even, or their general health too. So this person might stop exercising as much as they used to. There's a social component to it, but especially start thinking about somebody who might be really, really good, and they might be looking to turn this into a career. If you then falsely told them that they might have a heart condition, and therefore, you kind of put the scare factor in them, they might stop, and clearly that's going to impact someone's life. Now, in terms of the ultimate cost to society, of course, if you start ordering EKGs for everybody, that's going to cost a lot of money. So we already have, an issue with healthcare costs in our country. And if it's not going to be as effective as one would hope because of false positives or, or lack of ability to catch all pathologies, is it worth it? Sort of like a cost to or a risk to benefit ratio. And so Dr. Corrado has been known to do a lot of work on this particular topic. Their group, it's an Italian group, has a lot of different articles published on this topic. And so this information came from particularly from the Journal of the American Medical Association in 2006. But if you're interested in this topic, this lab group has published a lot of different works in this field. Okay, so of course, echocardiography is really one of the gold standards to evaluating heart pathologies within all populations, but definitely athletic populations. So it generates a picture of the heart, which can be much more useful than an EKG. It can assess the flow of blood through the heart. So this is one way that you can start to, again, pick up more information between pathological versus benign heart murmurs. You can look at the size of the chambers, the size of the wall thickness, and the motion. So this is like real time. I mean, you can watch the heart move. So that's another, beautiful aspect. Of course, you can take still pictures as well. However, there is no perfect tool, and echocardiography is also unable to rule out all cardiovascular disease, basically meaning you could possibly miss something even with an echo. And it's also a little bit more expensive than ECG, so you wouldn't do this on everybody. You'd have to have some indication to order this test. Okay, additional testing, cardiac MRI, also very helpful, especially if somebody already has indications of pathology. Of course, that's the only time when you would do this because MRI is expensive as hell. So definitely not something that would be ordered for all individuals. Of course, there's stress tests as well, like exercise treadmill testing. So looking to see how they respond to exercise. And this might be a particularly helpful tool because sometimes pathologies can be noticeable at rest. Sometimes they can only be noticeable as soon as the heart starts to have to work a little bit harder. Holter monitoring is also very common. So this is essentially like a smaller lead, so only like 3 lead most of the time, EKG that you wear around with you. So it's like a small device that you can just hook to your body, like on your belt buckle, and you walk around with it. Normally for anywhere from like 24 to 48 hours is what they would send you home with. 48 is pretty common. But again, you're relying on this instrumentation and the timing of this instrumentation being just perfect in order to pick something up. So I think I kind of mentioned to you guys, I have this like weird heart thing, and a lot of times it happens when I breathe in and jump at the same time. I don't know, it's weird. Although it has happened under other circumstances, but my heart feels like it is going to beat out of my chest. Like it is a really strong contraction and it's really, really fast. However, I don't know when it's going to happen. So it could be months without that happening, or, it could happen twice in 1 week. So again, that's one of the issues with some of these heart conditions is you might not be able to detect it even with access to some of this equipment. So that kind of brings in the last point here, that problems arise because individuals may need to be followed repeatedly over time to either rule in or rule out a disease. So if there's early indications of something that could be pathological, it's not uncommon for them to follow this person over time. So repeated measures of the same test to either determine, yes, this person does in fact have this pathological condition that we suspected, or no, actually with additional information, it was a fluke. It was explained by something else. Okay, so in summary, we can kind of use some take-home points here to summarize the sudden cardiac death in athletic populations. So there's increasing evidence supporting the use of ECG or EKG screening. People really used to not believe it was worth it, but there is some growing information that suggests it might be a worthwhile practice. Again, there's still problems. Cost to society. What happens if you get false positives? No matter what we do, we're still going to miss some cases of sudden cardiac death. And, I know that there are even people in our class now that have been aware of circumstances like this. And, we go back to some NCAA high school or even professional athletes that all of a sudden dropped dead. And unfortunately, it just wasn't picked up with the current technology or implementation of that technology that we currently use. It will cause some long, expensive, and indeterminate workups. So, that's really one of the issues here. And as we talked about before, if it's only about 1 in 250,000 individuals that have sudden cardiac death, some people will argue, and it's sad to think about, that it's not worth the cost or the time. It's an interesting thought that, really drives home policymaking and really evaluating what's important to society. However, of course, the upside is that you could save lives, and it does happen. People do get readings. I think I told you about not that long ago, like about a year ago or so, there was a news story about somebody who was in NCAA athletics. He was a very good basketball player, and while he was in college, he was detected to actually have Marfan syndrome, and he didn't know that before. And so he was faced with a choice. Do you want to continue to play and run the risk of sudden cardiac death, or do you stop playing? And he decided to stop playing, that his life and his health was more important to him. So in that case, saved a life. So that really summarizes what we didn't get to last class. And please then look for the slideshow on the first part of our hypertension discussion.